Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. Today we have the honor of having Y.R. Yadav, the president of the Neurological Society of India, giving a series on neuroendoscopy, series of 12. And to run the proceedings, we have Narayan Swami, a neurosurgeon from the same hospital as Dr. Yadav. Welcome, Narayan.
Thank you. Thank you. So, good evening, everybody. It's good evening in this part of the world. Okay, I again welcome you all to this second episode of Neuroendoscopic lecture. We have distinguished panelists with us, and Professor Yadav John has told that that he will be giving the series. First, I'd like to introduce Dr. Suresh Sankla. Dr. Suresh Sankla is a senior neurosurgeon. After his formal training in US, he has developed keen interest in neuroendoscopy. He has been the past president of Neuroendoscopic Society of India, and he is now working in Global Spinal Hospital as HOD. Welcome you, sir. And Dr. Ashish Tandon, a prolific neurosurgeon. After his formal training in Australia as well as in Canada, he has been practicing in Jabalpur. He has done wonders. He has done a lot of minimal invasive surgery, and then he is also an executive member of the Neuroendoscopic Society. In fact, Dr. Ashish has conducted many series in the Neurosurgical TV with John Bennett. We are fortunate to have you both, sir. Welcome you. So now I'd like to introduce Professor Yadav. Professor Yadav needs no introduction. As John has said, that he is the president of Neurosurgical Society of India, and he has been a devoted teacher. He has trained more than 850 candidates in neuroendoscopy throughout India. Plus, he started from scratch and built up the state-of-art Neuroendoscopic Society in Jabalpur. So you name anything in spine as well as in brain, he has done. He has given many platform presentations. He has conducted many workshops. He has been the dignitary in many of the esteemed institutes like PJ Chandigarh, STPGI, Shuchitra, and even abroad. He's conducted many webinars. We are fortunate to have you, sir. And I'll hand it over to you, sir, to conduct this topic, sir.
Thank you. Thank you, Professor Swami. I'm grateful to John Bennett for giving me this opportunity to discuss endoscopic series. I'm grateful, and I'm thankful to Professor Suresh Sankla, sir, who has given his consent to be part of this webcast, and Dr. Ashish Tandon for sparing his time. Both are wonderful neurosurgeons and doing good neuroendoscopic surgery. Along with Professor Swami, he's working with me for such a long period. Thank you, all of you. And without wasting any time, I share my screen. Is that all right?
Perfect.
Sir. So today I'll be discussing the endoscopic excision of colloid cyst. I think I can bring it somewhere. I don't know. That part is okay. So endoscopic excision of the colloid cyst with the help of indigenous tubular retractor. So you can do it with the tubular retractor. So what I am talking today is the endoscopic excision of the colloid cyst using endoscope and also using tubular retractor. So I'll be discussing what are the advantages of adding tubular retractor with endoscopy, because you can also do this surgery with channel endoscopy. So colloid cysts are benign cysts. A patient may remain asymptomatic for a long time. Some can present with paroxysmal headache, gait disturbances, nausea, vomiting, behavioral changes, weakness in lower limb, impaired memory, and maybe new learning disabilities. And unfortunately, some of them may have sudden death. So this is not a benign problem. So we need to understand. In the investigation, usually if you do a CT scan, it is a well-defined round or oval non-enhancing lesion. If you see in CT scan that if there is a hyperdense cyst, then this cyst is may be difficult to aspirate. This may be a candidate for maybe you might have to add along with the endoscope tubular retractor. So difficult to treat by pure channel endoscopic surgery because the contents are thick. In MRI, the MRI signal intensity usually are variable with any combination of T1 and T2 signal intensity. Most commonly, the appearance is hyperintense on T1 and iso to hypo intensity in T2 sequences. Again, if you find low signal intensities on T2 weighted sequences, these patients have again high viscosity and it is difficult to aspirate the cyst content. So again, it is difficult to operate with the help of channel endoscopic surgery. But if you add tubular retractor, then the surgery may become little easier. Whereas majority of high signal lesions on T2 weighted are easy to aspirate, and therefore even you can remove it using a channel endoscopic surgery. The hyperintensity on T2 flare, if it is present, whether it is homogeneous or there is a rim of hyperintensity peripherally or there is a dot sign, then these cysts are dangerous. So they have been associated with the large size of the cyst, or if you find them small, then very rapidly they become large and they are at higher risk of producing obstructive hydrocephalus. And therefore, even if they are asymptomatic, you should be very careful in during the observation. Now, the most important thing is decision making. If the patient is symptomatic, then there is no problem. We have to do surgery. But if the patient is asymptomatic, we need to know the risk score of the colloid cyst. So if the risk score is low, that is 2 or less than 2, and I'll discuss what is the risk score, then you can observe them. But if the risk score is 3, then in these cases, you need very close observation, including clinically and radiologically. That also I'll discuss. But surgery is certainly indicated when there's a risk score of 4 or more, or the patient is symptomatic, or if there's associated hydrocephalus. What are the surgeries that I'll discuss? Before that, let us discuss what are the risk factors. So these are 5 risk factors, and I think the limitations of this risk score, colloid risk score, is that they did not take into account the hydrocephalus. So maybe the 6 risk factors are there. So age, if the younger is the patient, there is a possibility that during lifetime they may develop symptoms. So younger the patient, they should be given preference for surgery. The headache, presence of headache, the diameter of the cyst, if it is 7 mm or more, The flare hyperintensity, I have already discussed that if the cyst is flare hyperintense, they are likely to enlarge, and these cysts become large very quickly and may produce hydrocephalus. So these are also the presence of flare hyperintensity is a risk factor. So that is also counted as point one. And the risk zone. If the lesion is there at the risk zone, so what are the risk zone? There are 1, 2, 3 risk zone. If the lesion is placed near the foramen Monro, then it is a dangerous situation because this cyst can obstruct foramen Monro and can produce obstructive hydrocephalus, and these patients may deteriorate. But if it is at zone 2, then because there is no vital structures there, but risk 3, I mean zone 3 is also near the aqueduct of Sylvius. So if the lesion is at zone 1 or zone 3, then these patient may produce obstructive hydrocephalus and can deteriorate suddenly. So presence of risk zone, that is cyst present in zone 1 or 3 are the high risk zone. And out of all these risk zone, I think the hydrocephalus and the younger the age, the flare hyperintensity and presence of the cyst in the risk zone of 1 or 3 are the most important, although others are also the cyst size and presence or absence of hydrocephalus is important. So if you have less than 2, then you can observe them, but 3 needs very close observations. And if these 3 have flare hyperintensity, and if these are present in the risk zone and in a young patient, then it is better to operate even if the patient has a risk score of 3. But if it is 4 or above, and if it is associated with the hydrocephalus, and if the patient is symptomatic, surgery is definitely needed. About the various types of surgery which can be performed, you can have microsurgical excision, which
Are you there, Dr. Yadav? Seem to have an audio outage.
Professor's
Hello?
voice. Yeah, Professor Yadav's voice is gone.
Yeah, it has. I noticed. I think he fell off. Oh, there he is. Okay, you're
He's
back.
muted. He's muted. Can you unmute him?
No, he has to unmute himself. Go
Okay,
ahead,
I'll tell him on the
Dr.
phone.
Yadav.
okay.
Yeah,
Okay. So I think I'll have to share my screen again.
Yes, please.
Yeah, I think so. No problem.
Okay.
Okay. So is this visible now?
Yes.
Okay. So stereotactic aspiration is again on another modality, but you
Uh-oh. Yeah.
Again gone, John.
Yeah. I think he's at a computer. I don't think the connection is great. Unfortunately. If you can hear me, Dr.
Yeah, I can hear you, but then, yeah.
You can hear me, Dr. Yadav? Doctor, can you, I don't think you see his screen is frozen.
Can you hear John Bennett?
Yeah,
He's trying to speak to you.
he's trying to text me.
Yes. आपका नाम ही नहीं है इधर. He has to
Okay,
introduce your guest again.
I'm
Yes,
sure
sir,
he's,
you come.
I'm sure he's
Unmute,
trying to
sir.
get back, he's
Please
trying to
unmute.
get back in. Just be patient.
Yes, sir, please unmute. No, sir, you have to unmute. Unmute, sir. You have to unmute, sir. Yes, sir.
Yeah.
Only after unmuting you'll come, sir.
Uh,
Call Mr. Sir. Sure.
Um, okay, I think he fell off.
Yeah, he's trying. John is trying.
Okay. No, it always works out. Just be patient. It always
Okay.
works out. It always works out. The digital coffee break. Well, I'm glad his daughter's there. She's probably
He
set it up.
hasn't come. He's trying.
Is anybody in touch with Dr. Yadav at all?
I can only ring him up. I rang him. I'm rang him up. He is trying.
Oh, okay. So he says he's trying. Okay.
Yeah. He has to. John, can you allow Professor Yadav to join again?
I'm sorry. Could you repeat that, please?
Yeah, allow him to join again, please.
I'm looking at I don't see anyone trying to join.
आप भी टाइप कर लीजिए सर, प्लीज allow me to join again.
Oh, there he is. Okay, back.
Yeah, he's okay.
Okay.
Yes, sir.
Okay, let's try it again.
Okay.
Share screen, sir.
Yeah. So, is that okay?
Yes, sir.
Full screen, please.
Allowed to, yeah.
There you go. Perfect, perfect.
Yeah. So, sorry. I think what I was talking before, I don't know whether I was here and then type of surgery. So the surgery is indicated when definitely if the patient is symptomatic and if the risk score is 4 and above, and if there's a ventriculomegaly, that is hydrocephalus, then definitely these patients are at high risk and may deteriorate and die. So therefore, surgery is 100% indicated. There is an intermediate risk zone which requires very close observations, that is risk score of 3. But if such patients have flare hyperintensity, which I have already discussed, or if the cyst is present in the risk zone, high risk zone, that is risk zone 1 and 3, and if the patient is young, then in such case you should give benefit of doubt regarding surgery. But if the risk score is 2 or less, asymptomatic patient, incidentally detected elderly patient, then in those cases you can just observe these patients. Now, I have already said that there are different type of endoscopic surgery. One is the channel endoscopic surgery. This is the example in which you have an endoscope and you have a working channel. There is an irrigation channel and aspiration channel. So these are the classical endoscope available for ETV or intraventricular surgery. The cyst also can be removed through this, but there are problems. The instruments are passed through the working channel. It is pure endoscopic surgery, but there is a difficulty in bimanual dissection because you can pass your instrument through the working channel only. You cannot have a definite angle. The bimanual dissection is difficult. So in these cases, there may be problem in dissection of the cyst wall from the roof. And in removal of this, you might pull the cyst and cause bleeding. So difficulty in bimanual dissection is there. And if there's a bleeding, then there is a difficulty in controlling of that bleeding. And therefore, the channel endoscopic surgery are suited for small and avascular lesions. And if you have hyperdense cyst on CT scan or hypointense T2 with the high T1 signal, that means the cyst contents are having high viscosity and difficult to aspirate. So these patients are difficult, these cysts are difficult to remove using channel endoscopic surgery, or if the cysts are very large. So in such case, either you go for open or microscopic surgery, or you use endoscope along with the tubular retractor. That means you use the port system, which I am discussing today. So in the endoscopic control surgery using port system or tubular retractor, The instruments, this is the example. The endoscope is stationed at one corner at the margin, and then the instruments are passed by the side of the endoscope. It's a pure endoscopic surgery. There is no difficulty in manipulation of the instruments. And there is easy bimanual dissection. So you can dissect the cyst from the roof of the third ventricle and the vascular structures there. And there is no difficulty if there's any bleeding because it is there in the air media. And because of these two advantages, even very large lesions or vascular lesions, apart from the colloid cyst, even if there is a lesion which is very large and vascular, can be operated using port system and endoscopy. Whatever are the limitations of channel endoscopy can be overcome by the tube system. The other may be the microscopic endoscopic assisted microsurgery, but the problem is difficulty in visualization of the corner. You may not be able to see the cyst attachment with the roof of the third ventricle. So apart from that, but it is a useful adjuvant. If you find problem in early learning curve of your endoscopic surgery, so with the help of tubular retractor, you can take microscope and complete your work. So this is one of the method which can be used. So if you combine endoscope with the tubular retractor, then some of the limitations of channel endoscopic surgery, which I have already narrated, can be overcome. Regarding the tubular retractor or the conventional retractor, Lila retractor, which we use, we all know that in tubular retractor, there is a less retracting pressure, and this is because the pressure is distributed in all directions and there's a large surface area. So because of this, these are better than the conventional Lila retractor. And I use my own indigenous tubular retractor, which I think is unique in two properties. One is that it is very soft. It is made of silicone, therefore it does not cause any harm to the brain, surrounding brain. And the second thing which we have done is that we have put in a longitudinal cut. And this is the great property of this tubular retractor. Because of this cut, it can be folded. So you can introduce this tubular retractor through a very small opening. So during introduction, you can reduce in size. And also during surgery, if there is a raised ICP, the retractor folds itself rather than causing harm to the brain and causing pressure on the brain. Is just hold the brain, and if there is a raised ICP, it collapses. So it's a dynamic, the tube changes its shape dynamically. When the pressure is less, then it expands fully. Regarding the technique, the burr hole position or a mini craniotomy, which is done, depends upon the cyst location in relation to the foramen of Monro. Usually it is 3 centimeter anteriorly or 3 centimeter away from the midline when you use channel endoscopic surgery, but you can use navigation to find out exactly, because you have to go dot on the foramen Monro, and also you should have access to the roof of the third ventricle. So your trajectory should be such that you should be going on the foramen Monro and you should be able to see the roof of the third ventricle, because from there is a adhesions, attachment of the colloid cyst with the roof of the third ventricle, so that you require to dissect. So when we use tubular retractor, then I use superior frontal gyrus approach, which is better than the middle frontal gyrus, because the amount of damage done to the white matter tract when you use superior frontal gyrus is much less compared to middle frontal gyrus. The dura is open. I use pile stitches so that the brain does not fall away from dura. I use transcortical approach, and we use tubular retractor, and about 2 to 3 stitches are applied on the outer margin of the tubular retractor. The ventricle is entered at the foramen Monro. This is a very important step. If you go little more anterior or posterior, there will be a lot of difficulty in surgery. So you have to land exactly at the foramen Monro. The choroid plexus near or at the cyst is coagulated. So choroid plexus there is coagulated and cut, and also the cyst wall. And you aspirate the content of the cyst wall so that it becomes very thin, film-like, and then you pull it back in the lateral ventricle. In the channel endoscopic surgery, you can use rotational technique. That is, you hold the cyst and then just rotate rather than pull it back. So this has been found to be good by some authors, but in tubular retractor, you don't require this technique because you can go for bimanual dissection and you can dissect cyst wall away from the adhesions all around. Now, there can be situations when the colloid cyst may be a little posteriorly attached. So if it is there in the middle or in the posterior third of the third ventricle, in that case, you might have to enlarge the foramen Monro. If it is there at the bulging at the foramen Monro, then you can take transforaminal approach. But if it is going posteriorly, then you may you need to enlarge the foramen Monro, and that can be done using either suprachoroidal or subchoroidal approach. For that, you need to know the venous angle. So the venous anatomy you must look for before surgery. If the venous angle is posterior to the foramen Monro, then without sacrifice, you see, if you have to go for suprachoroidal approach, you have to coagulate the anterior septal vein and then retract this internal cerebral vein laterally. So you have to go in between these. But if the venous angle is much more posteriorly placed, then even without sacrifice of anterior septal vein, you can gain some access and do surgery. So septal vein may be sacrificed if the venous angle is at foramen Monro, like in this case. If it is there, this is foramen Monro, septal vein and thalmostriate vein joining, making the internal cerebral vein. If it is there at the foramen Monro, then you have to sacrifice internal anterior septal vein. But if the venous angle is much more posteriorly, as in this, then in that case, you can just extend, you can open the choroidal fissure and you can gain sufficient space without sacrifice of anterior septal vein. This diagram shows that there can be, when you extend the corridor posteriorly to the foramen Monro, then you can take either suprachoroidal approach or subchoroidal approach, or you can go interfornices also, which is shown here. When it is suprachoroidal, then it is in between the fornix and the choroid plexus, as shown in this line. But if it is subchoroidal, then it is between the choroid plexus, the thalmostriate vein, and then it is lateral to the internal cerebral vein. But if it is suprachoroidal, then it is in between these internal cerebral vein. And interfornices approach can be taken if you have a large cava septum pellucidum, the space is there, or if the if the cyst has migrated up in between the two fornix and separated them by its position, which I'll show you in some of the next diagram. So you can have interfornicial approach, but there is a risk of damage to both the fornix. So it is not preferred except if you have some septum pellucidum or suprachoroidal or subchoroidal approach to reach in the third ventricle. And this diagram shows when you have to take the interfornicial approach, when the cyst has moved up and it has separated both the fornix away, or there is already a cavum septum, there is a cavity through which you can go without damaging both the fornix. The important points in surgery is the septum pellucidum is open. Otherwise, problem is that because the opposite ventricle is dilated, so septum comes in your way. So you should always open the septum pellucidum, and so that it does not bulge, or otherwise this is also helpful in the post-operative period. There should not be any injury to the thylamostriate vein and the internal cerebral vein, and you should always plan for complete excision. But if it is not possible, then you can go for subtotal excision, but coagulate the residual cyst wall. So if the total excision is not possible, you remove whatever is maximum cyst wall is possible, coagulate the cyst wall. Usually it does not grow. So in long-term follow-up, there is a low risk of recurrence. And if the recurrence occurs, then it may take very long time, or there may not be any recurrence at all. This is a short video. The colloid cyst. A small craniotomy, the nasal speculum introduced in closed position. And then you put in a tubular retractor inside this, as shown here, folded tubular retractor. And once you put it, then you take out the nasal speculum. And you see in the beginning of your this thing, the tube is already folded. So you, because there is a raised pressure, so and after that you station your endoscope at a 12 o'clock position. You can observe the cyst. You must land at the foramen Monro. If you go at other place, so planning is important. Now this is the coagulation of the choroid plexus using single limb bipolar forceps, which is meant for endoscope, and then you cut the choroid plexus so that when you take out the cyst wall, there is no bleeding. And so you separate this, and then you also remove the content of the cyst wall, open the cyst wall, aspirate the content, and then you separate the cyst from the surrounding structures as shown here. And using a sharp dissection, you can dissect them around. When it becomes small, then you can bring it in the lateral ventricle. So the adhesions to the roof of third ventricle is coagulated, and then it is cut using scissor, some more adhesions. So these things are not possible when you use channel endoscopic surgery. So what you can only do is that you just try and rotate it and try to blindly take it out, which increases the risk of bleeding. And at times you are not able to remove cyst completely. So this is a complete excision without injury to the fornix. So in the surgery results, we have done quite large series of more than 148 colloid cysts, and we have experience of all kinds of surgery. We have initially used microscope, and then I started with the channel endoscopic surgery, and then I found that there is some problem in dissection of the cyst wall. Then I switch on to the port system. And now with more than 48 cases, I am satisfied, and all cases we have been able to remove the cyst completely. So the complete excision was done with the tubular retractor versus about 90%. And all the time you are worried whether there is some bleeding when you try to just separate the cyst wall from the third ventricle. So in the channel endoscopic surgery, post-operative, you can have hydrocephalus. Some of them may require shunt, but most of them, if you just observe, the hydrocephalus disappear. There was one death because of the infarct. Possibly there was progression of thrombosis in thalmostat vein. The length of stay and the operating time was significantly reduced as compared to microscopic surgery. It is minimally invasive, it is safe, and it is effective. The advantage of our retractor compared to other tubular retractors, I think all of you know, one is that it is inexpensive. Not even 10 rupees, Indian 10 rupees cost. Simple, it helps in stopping the bleeding. It changes the shape dynamically, apart from being transparent and having other advantages. So another video. This is a cyst wall. See, it is hyperdense. So the cyst content are thick, viscid, so many craniotomy. Then opening of the dura. Usual steps of surgery. And coagulation of the and then introduction of the nasal speculum and tubular retractor, and then you take out the nasal speculum. The endoscope with the help of telescope holder is stationed at 12 o'clock position, and now the normal bipolar forceps is used to coagulate the cyst wall and the choroid plexus, which are then cut to separate the choroid plexus from the cyst, and also cyst wall is cut so that the content can be aspirated. And then you bring the cyst, I mean, after reduction of the cyst content, but since it was a thick content, so I mean, it was quite bulky, so I had to separate it from bimanually from the surrounding structures. And this was possible because you can use 2 instruments or 3 instruments. So bring that cyst in the lateral ventricle and then coagulate and cut it. And that is, so this type of surgery is not possible with the channel endoscopic surgery. So what I am trying to stress. So this is the pre-op images and post-op complete excision, pre-op and post-op complete excision. Another case, pre-op, post-op, pre-op and post-op. The combination of the endoscope and tubular retractor has been used by many authors, including our own series, where we use tubular retractor in deep-seated brain tumors and also intraventricular tumor. And this was found to be safe and effective. These three studies are from our center. Newman et al. Also used these combination of tubular retractor and endoscope along with Gassi and Jamshedi et al. And they found that this combination is really very good and effective. But there can be complications. There is a steep learning curve. You can have epilepsy because it is transcortical, but since it is a minimally invasive technique, so many people, including our own experience, shows that the incidence of epilepsy in transcortical approach using minimally invasive technique is very minimal. You can have hydrocephalus. There can be decreased memory if you injure the fornix, hemiparesis, venous infarct, or there may be difficulty when you don't have associated hydrocephalus, but you can hit the ventricle using image guidance, or you can track the ventricle passing the soft ventricular catheter and then following that catheter in the ventricle using endoscope. For detail, you can see our article which are published, and also chapter 13 in neuroendoscopic surgery, a comprehensive approach, which we have written, and this chapter deals very well about the operative nuances and the complication avoidance in colloid cyst. So to conclude, channel endoscopic surgery and the microscopic surgery are also effective alternate. I never say that this is the only approach. So these also can be done, but there are difficulty in bimanual dissection of the cyst wall and the control of hemorrhage if it occurs when the lesion is T2 hypointense in MR and CT hyperdense lesion, and those lesions which are placed posteriorly in the third ventricle. So in that case, you require a little more bimanual dissection. So channel endoscopic surgery in such cases are difficult. So endoscope with tubular retractor is especially useful in this subgroup, and it can also be useful in simpler cases also. The total excision of the cyst should be the aim. So total excision and control of bleeding is better using endoscope and tubular retractor than the channel endoscopic surgery. If there is a difficulty in endoscopic surgery in the beginning of your learning curve. So if in endoscopic surgery in colloid cyst, if you have problem, then you can bring in microscope and complete your surgery. So this is another advantage of using a tubular retractor. So you can bring in microscope and complete your surgery, although total excision should be the aim. But if it is not possible, then you can go for subtotal excision and coagulate the residual cyst wall. Usually these remain asymptomatic for very long period, or they may not be recurrence at all. But there is a steep learning curve, and there you need to understand and practice endoscopic surgery. Thank you very much. Thanks.
Thank you, sir. That was a lucid presentation again, as you have been presenting. You have discussed almost everything, where the cyst is, how to identify, and the danger zones, and how to approach if it's present in. Now I invite the panelists to continue the discussion based on his descriptions. Dr. Suresh Shankla, sir, and Dr.
Yeah,
Ashish.
hi.
Sir.
Hi, good morning. I'm Marco Antonio Barajas from Guadalajara, Mexico. Professor, thank you very much. Excellent presentation. Okay. I have 20 years working with the endoscopy, and you comment is very important, the tubular axis when the cyst is very big. It's very good working. Congratulations.
Thank you, sir. Thank you. Thank you very much.
Thank you. Thank you, Dr. Yadav, for showing us the right way to remove the colloid cyst, do the colloid cyst surgery using the endoport. I really appreciate the way you have really described it, and what you said is very important is the location of the colloid cyst makes a lot of difference. So you should be able to read your MRI scan very carefully and see what kind of colloid cyst it is and what exactly is the location. Many a times you find that the colloid cyst is either extended anteriorly or posteriorly, or many times superiorly. And this is the area which is very critical in terms of deep vein locations. So you have to really identify the location very carefully and then choose the approach. While choosing the approach, as you said so correctly, that where to make the craniotomy is very, very important, because if you miss the, or you are not aligned with the foramen Monro properly and the location of the colloid cyst, you end up having a lot of trouble in accessing that colloid cyst. So reading the preoperative investigations and identifying the location is very, very important. Your understanding of the anatomy is so beautiful, and the way you have showed how you can remove these colloid cysts so nicely from their adherence. One thing I just would like to mention that many a time it is really very difficult to see the location if it is not particularly adherent to the area where you expected it to be. Then you have to do a little bit of manipulation, and sometimes bringing in the microscope is a very good idea. And as you said in the beginning of the career, but I would say even at this stage, I sometimes bring the microscope in. And this is another advantage of the port endoscope, the port endoport, because you don't have to change anything. You have to just remove the endoscope and bring the microscope in. And rest of the technique, rest of the procedure and process remains completely unchanged. And you try this one, and I can give little bit of importance to this point to my younger colleagues and younger people in the audience, that colloid cyst is one area where you would more than welcome to bring the microscope in, because it makes a lot of difference. Otherwise, you said very correctly that the remaining part, which you think is very risky to remove, should be coagulated and then left alone. So it's a wonderful technique, and the way you have explained it, looks so nice. Thank you very much, Dr. Yadav.
Thank you, sir. Thank you.
Can I
Ashish.
jump in? Yeah. So I would take this opportunity to be the one who wants to complete this juggernaut of colloid cyst. And unlike sir, I do microscopic and channel endoscopy. So there are a few things that I would like to mention for the sake of completion. So as far as channel endoscopy is concerned, the entry is far more lateral. You go much more because you want to see the roof. And even when you're using a 30-degree scope, if you're going through the superior frontal gyrus, it may be difficult to look to the roof. So you tend to go lateral as possible. So generally, to be fair enough for the students, it's generally I take about 7 centimeters lateral from the midline. And I also tend to go anterior, almost to the hairline, because the colloid cyst generally originates a little posterior to the foramen of Monro. So the wall is just anterior part of the third ventricle. And so if you go anterior, you may get a better trajectory. That is for channel endoscopy. Now, coming to keyhole endoscopy, there are two very important things that I have learned over the course. One is if I am not able, if the ventricles are very small, I tend to go microscopic keyhole. That's one. Second, and also if I'm not able to dilate the ventricle. So previously, before the navigation era, I used to shift to microscopic, but now that we have navigation, I tend to increase the size of the ventricle and then go channel endoscopy. But if there is a reasonably sized colloid cyst, which is a little posteriorly located, I would go in for a keyhole and microscopic approach, which I feel is much more controlled in my hands. But here, what I have learned is to see the venous anatomy. Because of this hype of keyhole and going for small incisions, we do not realize that when you're doing a microscopic parafalcine approach, if there is a vein from the superior sagittal sinus coming to the cortex, and if your opening is very small, then you do not have place to, either go anterior or posterior, and you may damage the vein. So in the enthusiasm of making it too small, I have had troubles. And now I go for a reasonably sized keyhole, so that even if I find, if on venogram I have missed, and even if I find a vein, I have some space to go anterior or posterior to that vein when I'm doing a keyhole approach to, prevent injury to the vein. So all in all, definitely, I think what Sir has told, when you have both hands, it definitely makes things easier and more fruitful. Rather, if you have one hand with the channel endoscopy and using just one hand. So it's great to see so many approaches coming up. And I think, again, there is, we need to emphasize again and again that do not injure the fornix, rather leave a part of the tumor. Just not to have the enthusiasm to injure the fornix in the interest of complete excision. Thank you.
Just one more comment. For the sake of completing your lecture, Dr. Yadav, just tell us about the surgical approaches using the endoport when the ventricle is not dilated, either normal or very small size ventricle. How would you approach the colloid cyst?
Sir, there are, in the past, we have learned that if the ventricle is small, then you go transcallosal. But with availability of the navigation, you can hit the ventricle in a small size. And there are series. We have done a transcortical approach using endoscopic surgery, tubular retractor, in a normal size ventricle. And there are reports that you can, once you can hit the ventricle and reach at a correct place, then things are possible. I know that the size of the ventricle, obviously the space is small, and at times the septum pellucidum also bulges on the ipsilateral side. So first important thing is that you go at the foramen Monro and communicate the septum pellucidum, make the opening there, and then you find sufficient space and work. We have done, I think, 2 or 3 cases in normal this thing. But if you are not confident or facilities are not there, it is better to go microscopic transcallosal.
Yes, I think the particular problem comes when the foramen Monro is very small, because with the help of navigation, you are able to enter the ventricular cavity. But as you go in, you'll find that the foramen Monro is very small, and the entire colloid cyst is hidden behind the fornices. And that is when I think you need to consider changing the approach. Thank you. Thank you very much for your
important. When you use endoscopy, you have 2 different techniques. You can use only endoscopic, put an endoscopy to take out the cyst, or you can parendoscopic. How do you show, Dr. Jada? Okay, it's important that you have the two different concepts, pure endoscopic or parendoscopic surgery. When you use parendoscopic surgery, you can use the endoscopic and the microscopic at the same time. When you use only endoscopic, it's only tubular. It's very important. Okay, it's important. The more important in minimal invasive is did you understand the physiopathology of the problem? Okay, and you can combine different techniques, in case, every case in special. It's very important. Minimal invasive is not a little keyhole. The minimal invasive is understand the physiopathology, all the anatomic structures around the tumor, and have a good evolution.
Yes, yes. Yes.
Dr. Yadav,
Yes, sir.
can I ask you one question? Very basic question I'm asking.
Sir.
Once you made a craniotomy, whatever size you are describing, and you opened the dura,
3
and you are
centimeters.
putting a speculum, how do you decide that speculum is going there only in the ventricle?
The
Because
trajectory.
speculum has it's a quite big instrument to go in.
Yes, you are
Like
right.
we used to hit with the brain needle, Dandy's needle, whether we are going in the ventricle or not. And that is how we used to say CSF has come and now we are in the ventricle. Now,
Sir.
as discussed by others also, and Suresh was also telling, the small ventricles many times difficult to hit.
You are right. So one thing, I think one is that you are right. It is always better to hit the ventricle with the brain, the ventricle needle, rather than putting this. The other thing which I do, I think if I have some photo also, I can show that I mark from entry side to the foramen Monroe, from coronal sutures to the external auditory meatus, and then at the depth of about 5 to 6 centimeters, there is a foramen Monroe. So I mark that, and when I make incision, I mark on the screen the trajectory in which direction I have to go. So anterior posterior, that direction should be there. This is how, or if you have a navigation, then you use navigation, but I did not have navigation, and believe me that I never went wrong. The most important thing in the surgery of the colloid cyst is reach at the foramen Monroe. If you reach more anterior or posteriorly, then you are in trouble. So I mark the trajectory before starting on the skin. I scratch the skin and then mark that this thing. If I have some, I think I can show my in any of the presentation. It is there that how you should mark that trajectory. In ETV also I have shown this, so you can understand in ETV that same thing applies here also.
Right. Do you do the third ventriculostomy after removal of a cyst?
No third ventriculostomy. No third ventriculostomy. If I share a screen and then I can show this how you go there. See, I think ETV, the exact size, yeah. So supposing this is the midline. Are you able to see that?
Yes, sir.
Yeah, we can see.
Yeah. So this is the midline. Supposing this is my incision here. This is the ear. So when and from coronal suture, you can mark coronal suture. So around at the depth of about 5 to 6 centimeter, there will be foramen Monro. If you draw a line from coronal suture to external auditory matters. So you can mark that this will be the foramen Monro there, and then from the incision plan you can scratch the skin and take that. So invariably it goes at the same place. This was the coronal suture. This is the lining towards the external auditory matters. So this gives me, because in ETV also you need to go there only, or else use navigation.
Right. Thank you. Thank you. Nice presentation. Nice.
Thank you, sir.
I hope that answers Dr. Harshad Parikh's sir's question, as well as somebody else has asked the same question. That do you do ETV routinely? After that, I think you answered that question, sir.
No ATV, no ATV. Sir, Dr. Suresh Sankla, sir. Sir, you are muted. Dr. Suresh Sankla, sir. Please unmute. Yeah.
Yes, I'm okay now. Just one comment, I understand, there's no need to do the ETV, but, considering a septostomy may not be a bad idea in many of these cases, because then at least you are communicating with two lateral ventricle, and it's a pretty simple procedure as compared to ETV.
Yeah, it should be done, sir. One is that the other side ventricle does not prolapse towards you. At times when you remove, when the cyst is compressing the ipsilateral foramen Monro, it presses also on the other side.
Other side, yes.
I always do septum pellucidum compression. For this, another is that later on, if there is some fibrosis and the foramen Monro includes, then it is always better. So
yes. I fully agree with you. Another simple basic question is that, normally you prefer right-sided craniotomy. All of us do that. Is there any indication where you should do the left-sided craniotomy for colloid cyst?
I think if
someone has asked the same question, there's an asymmetrical ventricle and a small ventricle on the right side and a larger ventricle on the left side. So can it be done from the opposite side?
Yeah, if
He's Dr. John, sir.
Yeah, when you think that there is extension of the cyst more on the left side because it is asymmetrical, then in that case you can go from the left side. Otherwise also, if the right side ventricle is sufficiently dilated, then you can go from the right side, open the septum pellucidum, and with the tubular retractor, obviously, you can manipulate things and can take it out. But the larger side ventricle, if you go, it is better it is.
Third, Dr. Yash Sampura is asking, what's the incidence of phonic injury with endoscopy?
And we have not studied, but patient did not complain. The memory disturbances, fine memory disturbances, neuropsychological assessments were not done, but patient did not complain of any this thing. You don't add on to the deficit. What is the main thing is that first you decompress the cyst wall. So do not try to go around the cyst and try to remove it. So first disconnect the choroid plexus from the cyst, number one. Then you make the incision in the cyst wall, try to empty it and make the large cyst into the small cyst, and then separate it from surrounding. In that case, you don't injure the fornix. So using that technique, I think unless you find that the whole cyst is the calcified, which we have never came across. So in that case, I think it is better to extend the use suprachoroidal approach, extend the foramen, the size, the opening of the foramen Monro posteriorly.
Dr.
So
Lal,
how
know if there's
the
bleeding, how do you manage it?
What?
If there's bleeding, how do you manage it, Dr. Lal Rehman, sir?
Yeah, in channel endoscopic surgery, there are problems. You have to wait, irrigate, and then convert large cavity into a small. That means you withdraw your channel and endoscope little bit, and then you can visualize and try to do a tamponade effect by sheath. So this is regarding channel endoscopic surgery. This tubular retractor endoscopic surgery is through the air media. So this is another advantage. So any bleeding from anywhere, you can recognize it very well. And then you can coagulate using the usual endoscopic bipolar or the usual bipolar. I use endoscopic bipolar. So the another advantage of this tubular retractor is control of bleeding is easy. In channel endoscopic surgery, if you have slightest bleeding, small little oozing, the whole thing becomes red and you are not able to see in the liquid media. Whereas in air media, you can see everything and can coagulate the bleeding very well.
Though you're told Dr. Shashiranjan wants to know how to make the foldable tubular retractor. I think last webinar you gave a detailed presentation of how to cut it. So he wants to do it again.
Yeah, there is a longitudinal cut. I think I can show again. There is no harm. Should I show again? Yeah. So this is the tube. Can you see? Hello?
We can
Yes,
see.
sir, we can.
Can you see this? This is a tube, this is a simple tube. This is a silicone tube which is 1.5 millimeter in thickness, and it is 2 centimeter in diameter, but you can have 1.5 centimeter also, because you can reduce subsequently once your experience, then the size of the tube can be reduced. So you make the longitudinal cut on this tube. So once you make longitudinal cut on this, then you can fold it and then hold this folded tube with the forceps. So one end of the forceps is inside the lumen of this and another is outside the folded tube. And then you put it inside as you have seen in the surgery.
I don't think there's any more question. So, panelist, any more comments, please?
Yeah, as far as sorry, sir, please carry on.
No, please go ahead. Please go ahead.
Okay, as far as the question of risk of injury, fornical injury with endoscopy is concerned, there's definite literature that vis-a-vis microscopic surgery, the endoscopic surgeons tended to injure the fornix much more. But one has to realize that it is because the amount of experience which we had with the endoscopy initially was narrow. Now that our experience has increased, so the chances of fornicial injury has been reduced. However, still it is said that microscopic surgery, as far as complication avoidance is concerned or completion of the excision is concerned, it is still considered as the gold standard. And the endoscopic surgeons need to match those results that we are getting through the microscopy. As far as bleeding is concerned, I have a very important dictum as far as endoscopy is concerned, especially channel endoscopy. And that is, see, it's like if you have a fire in a room, so you can't just spray from outside the door. You really need to come close to the fire and then spray on the fire to extinguish it. Similarly, when you are doing for channel endoscopy, you have to come as near as possible to the site of bleeding, increase the irrigation, and then try to control. There is no doubt about it that controlling bleeding with channel endoscopy, or for that matter, any endoscopy, is much more challenging vis-a-vis a microscopic or a two-hand technique.
Thank you, Dr. Ashish.
Yes.
Dr. Yadav, sir, your concluding comments?
I think the other questions being asked is that whether they can get the recording of this. So
John has already given the answer. Sir.
Okay.
He has given the
good.
answer that he has even got the links also. He has posted it.
Excellent.
Yes, anyone that wants to see this, go to the YouTube section of Neurosurgical TV. It's on there right now.
Okay, excellent. So I think I'm grateful to Professor John and Professor Swami, Professor Sankla sir, and my friend Dr. Ashish for helping us, and all the viewers. Obviously, without viewers, nothing is possible. You get encouraged because of your questions, comments. So thank you very much, and we'll try to make it more lively in our subsequent.
No, I think it was very lively. And what's the topic next week?
Endoscopic removal of the chronic subdural hematoma. It is very, very important. Very few people have described, and I'll give some important tips of how to do this surgery without any complications. We have been doing this last so many years, and it is excellent. The recurrence rate using endoscope, and it is especially very, very useful when it is septate subdural hematoma, where there's a solid component and there are bridging vessels, and the chances of recurrence is much less when you use endoscope in chronic subdural hematoma. So we'll discuss it in detail, and the complication avoidance also in the next webcast on Sunday.
Very good. Thanks, everybody, and we'll
Thanks.
see you next week.
See you.
Thank you, John,
See you
for
later.
providing such a good platform. Thank you,
Great.
Yadav
Thank
sir. Thanks,
You guys-
Suresh
you
Shankar
guys
sir.
use-
Thanks,
Have a good day,
Ashish.
everything.
You
Thanks,
guys
Ashish
used it
sir.
well.
And thanks, Marco Antonio.
Hi.
Thank
Hi.
you.
Yeah.
Thank you so much.
Thank you, everybody. Have a good day.